At this point, I introduce myself. I will present you the preliminary result of autologous transplantation of retina and choroid. Okay. Last year, I heard this talk. Our colleague, Dr. Tamer Mahmoud, presented his first case of autologous transplantation of a patch of retina to treat a myopic, chronic, very large, plurioperated macular hole. He presented encouraging results in terms of anatomical integration of the retinal patch and also functional results. Functional results meaning a gain in vision up to 20/50. I was extremely impressed, as you can imagine, and I decided to apply this technique to some of my patients. This is the first case that I operated, a chronic macular hole. I selected the same indication. This lady had been operated a few times, so she had no ILM left. Also, the autologous transplantation of ILM was difficult because the peeling had been done up to the arcade. So I decided to apply this technique. And you see the video of the isolation of a retinal patch. In this case, in the nasal side, as you can imagine, there's nothing written on the subject. So many issues are still open: where to harvest, how large, the technique. In this case, I decided to isolate the patch. I used PFCL, and then I moved the patch with a Thanos scraper inside the hole. I left some PFCL on top of it, and I started the PFCL silicone oil direct exchange. During the exchange, as you can see in the video, it was difficult to maintain the patch stable inside the hole. I repeated the technique, the exchange, a couple of times, and then I decided to leave PFCL in order not to lose the patch. So I left the PFCL for 1 week. The first comments were that I found difficult to manage the retina flap. I did diathermy at the edges of the flap before cutting. Probably it was not a good idea because the edges are what we need to integrate the patch into the macular hole. And probably I did not enough diathermy at the harvesting site after isolating the patch, and I found a mild vitreous hemorrhage for a few days postoperatively. In that case, I decided to leave PFCL, and I aspirated PFCL 1 week after for the difficulties in completing the PFCL silicone oil exchange. So you can see the edges of the patch are very difficult to see. This is still under PFCL, the first day post-op. 1 week post-op, the OCT actually looks good, and the edges of the patch are difficult to differentiate, and it seems to start integrated in the peripheral retina. This is 4 months post-op. It was difficult to interpret. You can see that there is this epiretinal fluffy tissue that it looked like a new finding. Still, I noticed no major improvement in vision. At high magnification, you can see initial cystoid changes in the flap and this new epiretinal tissue. It seemed to me like the patch was not integrating at all. And in fact, 2 months after, I could see a complete degeneration of the flap with atrophic changes, cystoid changes. So it was a complete failure. This was my second case. The indications were very, very similar to the first one. I decided to harvest the patch from the temporal side, very close to the posterior pole, thinking that the anatomy of the retina in this area might resemble more the retina in the fovea, although we have no cones, only rods. So I detached it with a bubble of air. I isolated the patch not completely. I left a small hinge, and then I injected PFCL. Under PFCL, I completed the isolation of the patch and then moved the patch in the fovea. In this case, I still decided to leave PFCL because I didn't want to manipulate the patch multiple times, so I did not risk to lose the patch with the exchange. But 3 months post-op, the observation of the anatomy was, as you can see, it was very disappointing with atrophic and cystic changes of the patch itself. Anyhow, I decided to move on because I know that other colleagues in the world are trying and they are reporting good results, so I didn't want to give up. This was operated for retinal detachment and macular hole, this patient. Well, here you can see 3 months. Now I am at 5 months post-op, and still the patch looks integrated. The patient have very poor vision, but I think in this patient vision could be compromised also for other reasons, so I cannot comment on that, only on the anatomical integration that looks much better than the previous one. The fifth case is the best one. You can see that you can observe the layers actually, and a good integration of the layers itself with the surrounding retina. I decided to follow this patient with microperimetry as well. These patients start to show a more central fixation. Her vision is now 0.1, and she can read 1 centimeter letters. So in this table, I summarized the first results of this technique applied for chronic macular holes. I did not share with my colleagues the success that they presented, although I understood that, as always, improving the technique and improving the selection might lead to some results. Some of you know that I have an experience with RPE choroidal transplant for exudative maculopathy with very encouraging results like this one. This is a patient that I operated a few years ago with just a choroid patch for exudative maculopathy. She can see 0.4. She has a good reading vision, and this is her microperimetry with showing central fixation and good sensitivity of the retina on the patch. So this is a case that I would never operate now with a choroidal patch, because I understood in the ears that a result like this, like the previous one, can be reached only if the retina is not compromised. So this is not a good indication for choroidal transplantation. But what if we transplant choroid and retina? This was the question. How to perform surgery? Nobody could tell me, as you can imagine. So I performed the usual choroidal patch under the fovea, harvested from the mid-periphery. And then I decided to harvest a peripheral patch of retina as well. The literature tell us something. it's been reported that from the very periphery, close to the ora serrata, there are multipotent cells that can be may become photoreceptors. For example, after PVR, after inflammatory response, as an inflammatory response. So I decided to harvest the peripheral retina. This is the pre-op OCT, and this is how it looks just 1 week after surgery. It's impressive to see the disappearance of the cystoid changes. So the foveal retina of the patient looks extremely good. This is the patch of retina in the subretinal space, and this is the patch of choroid, which is already revascularized. This is how it looks 8 months after. So the anatomy is somehow encouraging, but she has no subjective improvement at all. And she fixates outside the fovea. I'm observing that microperimetry is essential in this kind of surgery to understand what we are doing to these patients. Anyhow, I moved on. This is a second patient, very similar to the previous one, pre-op, post-op, still the patch placed in the subretinal space, because also formation of extrafoveal synapses are described. So it might make sense. But in this case, as you may observe, I had a deep atrophy of the fovea on top of the CNV. So what happened during surgery? During surgery, when I detached the retina, as we usually do to perform subretinal surgery, I induced a macular hole. This is the removal of CNV, the isolation of the choroidal patch. The patch is transplanted under the fovea. This is RPE and choroid, full thickness. And then you will see that I observe the presence of the macular hole. So I decided to perform surgery, which actually made more sense. I isolated a patch of retina from the equatorial area. I flattened the retina and with PFCL on top of the retina. And then I moved the patch into the macular hole, as with the technique of Tamer Mahmoud for the macular holes. So how does it look? This is the patch of retina, and this is the patch of choroid. So in this way, the layers are respected. And this is another case very similar to the previous one. This is the patch of retina. As you can see, partly is inside the macular hole, partly on top, but it doesn't seem to be significant. And she actually is the first patient that is showing a real improvement in vision. She refers a scotoma disappearance. Her vision is 2200 at 6 months. It was counting fingers. Her reading ability is improving, but most of all, the fixation seems to be more and more central in the follow-up months. So, in the end, more pictures of OCT and microperimetry of the same patient. And this is the table of the patient I operated with a combined choroid and retina autologous transplant. So the last patients that I operated are showing an improvement in the central fixation and microperimetry as well as in vision. What can I say on this technique? I think it's a very, very difficult technique. It's very difficult to manage the retina patch, so probably we are inducing also iatrogenic alteration of the patch that might compromise the result of surgery, so we have to learn how to do it, first of all. We don't know how to harvest, how to complete surgery. It's a completely open field. Is it worth doing? Well, at this point I can tell you that I think it is, because I was very, very disappointed last year with the first result, but in the last months, I must say in the last 2 months, this is very, very new, I am observing a better integration in the last patient that I operated and a real improvement in visual function. So I feel the need to move on. I think it's worth studying and learn how to do it. Thank you.
Brilliant technique, thank you. Very encouraging surgeries. Have these patients had PVR complications or not?
Okay, well, not yet. But as you have seen from the table, these are very few patients and with a very short follow-up. Even with the choroidal patch, I'm collecting all the data because I'm almost ready to submit a paper for publication. With the choroidal patch, I have 10% complication of PVR, retinal detachment and PVR. So I think it's comparable to usual surgery, slightly more, but I think it could be acceptable for this kind of surgery. I expect that this type of surgery might have the same rate of retinal detachment.
And your previous group with only choroidal detachment, and this group, small group, I suppose they remain with a silicone oil endotamponade for a long time.
A few months.
Few months.
Routine is 3 months, but it might.
So usually in 3 months
I remove the silicone oil. Yeah, and with the patch of choroid, I have observed, and this is what I'm publishing, I have observed that the patient that improve vision, they do improve vision after months. Some of them improve vision after 1 year. And if they start improving vision, they keep improving.
They cannot stop.
They keep improving for at least 2 to 3 years. The maximum visual acuity that I have observed in these patients is 0.4 to 0.7 in the best one, with a gain in reading vision and microperimetry as I'm doing now. So I think it makes sense to wait also for this patient with a combined transplant and judge the result after at least 1 year. A transplantation of any kind of tissue takes time to integrate and show a result. But none of us would have thought that the retina might integrate somehow. This is the best thing that we are observing with this surgery. Whether or not it will lead to functional results, I think it's very, very soon to say.
Yes, you pointed very good issue that the anatomy of fovea centralis is completely different than we substitute from the periphery.
Yeah.
So it may play a role in the gaining of vision.
Mm-hmm.
But thank you very much.
Thank you.
Dr. Parolini, thank you very much for sharing your experience, great experience in that field. I just want to share my experience, if you allow me. I have done just 2 cases of autologous retinal transplants, and my...
for which indication?
For unclosed chronic macular holes after few surgeries.
Yes.
And my experience with perfluorocarbon is similar to yours. So I decided to do without perfluorocarbon. I directly did a fluid air exchange and then put silicone oil. And the
So how
transplant
did you keep the patch?
with a
during-
forceps by
with the-
manually?
Ah,
Yes. And it worked better than with perfluorocarbon because first time my transplant was attached to perfluorocarbon bubble and it moved with the bubble. So I decided to move it out.
yes.
And the second point I want to share is that I tried a little bit to stabilize the transplant with pushing within the edges of the hole. So at least because my cases are not such longer, I did them half a year ago. So anatomically, they look great. I cannot say anything about functional improvements because
They did not
Probably.
improve.
slightly, maybe from 0.05 to 0.1. First case and the second case from counting fingers to 0.05. But anatomically, they look, up to now, they look good.
Yeah.
One question is for you, maybe you have more experience with that, because I heard some people are doing under gas tamponade. Do you have any experience with that?
No, the cases that I operated are under silicone. I had the feeling, or at least I asked myself, whether the PFCL might have induced some kind of toxicity. I thought that looking at the post-op OCT and the changes, especially in the patients that I left under PFCL for 1 week because I was not able to complete the exchange, it might. We will see by changing the technique whether the anatomical improvement can be obtained. As far as vision, I can tell you that since I am performing microperimetry, I understood that we can't say anything on vision until we do microperimetry. There are patients, you can't imagine where the patient can fixate and have good vision. I have a patient with good sensitivity on the nasal retina, and she has developed a nasal point of fixation. It's unbelievable. So we cannot comment on those results unless we see that the patient can fixate on the patch. That can tell us that the surgery is working, otherwise we can't say anything.